This is Addiction Medicine Journal Club. I'm Dr. John Keenan.
And I'm Dr. Sonya Tredici.
We believe that addiction is a disease that can be treated, and we want to help you stay up to date with the latest research that you can use in your addiction medicine practice. The podcast offers a Category 1 CME through MyCares and Michigan State University. The links for the CME are in the show notes. This week, we're going to be discussing contingency management and how it saves lives. Sonya, how are you tonight?
I'm doing wonderfully. How are you doing?
Great. Living the dream. Living the dream as always.
As always, living the dream in primary care in central Pennsylvania.
Man, I also my daughter has the flu right now, my 5-year-old.
Oh no.
And of course, when your kid's there, you're like always snuggling with your kids. So this is going to be a true test of the flu vaccine's efficacy this year.
I'm really glad we're recording now before you get sick.
Let's see how this plays out.
Yeah,
Did we
I don't
match
know,
the strain?
Like at least 3 people with the flu breathed on me today, so it's just a matter of time. I had something I wanted to share with our listeners in the news this week about addiction. I mean, actually was a few weeks ago, and I don't know when this episode is going to air, so maybe it'll be super old news by the time it plays. But it was about the continuation of telemedicine regulations and telemedicine capabilities for addiction. So, John, do you use a lot of telemedicine for your buprenorphine patients?
I do a moderate amount. Yeah, it's situational, right?
Do you have like a standard, or is it up to each individual patient whether they want to do telemedicine or not?
You know what? It often starts with a series of chaotic phone calls the day of some sort of crises where they can't make it into the office. I feel like that's what ends up being the most. I do have some people that are with me like for long term, and we'll do tele visits at their convenience just because they've been doing well for so long, and they just kind of meet other program requirements in between the visits at their convenience.
Yeah. Yeah, I agree. I do quite a bit for my buprenorphine patients. I mean, to me, it's been a real godsend. Because we just have a lot of patients. I mean, they maybe have better things to do than go to the doctor, and they're super stable and they can do the visit from work. A lot of my patients have really bad jobs that are inflexible and don't give you time off. And so they can do these quick telemedicine visits from work, or they don't have transportation. We're in a rural area without public transportation. So that's a huge issue for people. Or like you said, there's chaotic phone calls the morning of, car's broken down, kid is sick. Job called you and you have to work. What are you supposed to do? And we can convert those people to telemedicine pretty quick. So it's a real godsend. And then, we had these telemedicine regulations that came into play in COVID times, and Congress had been renewing them every year. And this year they actually let them expire. And they reinstated them eventually, but there was a brief time when we were told we weren't allowed to do telemedicine. And then finally they did extend those regulations. So what we have right now is it's the 4th extension. So the 4th year they've been extended. It will continue to allow the prescribing of controlled substances to patients via telemedicine without requiring an in-person brick and mortar evaluation. So that was one of the previous regulations. You could do telemedicine, but only after an in-person evaluation, which pretty much made these telemedicine only practices not viable because you had to have an in-person place for the patient to go. So that got extended through 2026. So you don't need to see patients in person to start telemedicine. And they also made permanent the ability to do audio only telemedicine for treating opioid use disorder. Because honestly, I try to do video, but more often than not, I won't say more often than not, but a lot of my video visits kind of crash and burn. I don't know about yours, but I can't see the patient. They don't have Wi-Fi. Their phone's not working. I don't know what they swear they're pressing the button to activate their camera and nothing's happening. They have terrible phones that they got at Walmart. So audio only ends up being what I do for a pretty good number of people.
Yeah, I mean, it's hard. There's always some sort of tech challenge. I feel like it's just one more element of possible failure in the day, right?
Yep.
They work well for a lot of people, and it meets people where they're at. Like, I have some people though, they're doing it like on the factory floor at Amazon. I'm like, is it okay to be talking openly in this setting?
Yeah. My favorite telemedicine visit was with a very lovely person who was, I don't want to share too many details, but let's just say this person did the visit as they were on the bus coming back from their job site, and I realized they were on the bus, and then they panned the video, and the bus was full of their coworkers, and then all the coworkers started chiming in on the video visit and giving their opinion on the patient and their progress. It was really funny.
My favorite one was getting off topic now.
Yeah.
My favorite one was it started in one of my people was wearing a cowboy hat, boxers, and had a gerbil on their belly, and they were laying in bed, and that was it. And I had to tell them, I'm like, it's like 7-Eleven or Walmart, man. It's like, you got to have a shirt on for this. But the gerbil was the gerbil and the cowboy hat, whereas the icing on the cake there.
Another favorite. I had someone who did his video visit from the Philadelphia Eagles like Super Bowl victory parade, and we got to talk for like 3 minutes till it became too loud.
Yeah. All right. Back on topic.
But yes, we love telemedicine, and we're very happy that we can still do telemedicine. And thank you to our congressman for temporarily allowing us to do telemedicine. Again, we hope that next year the telemedicine will be extended permanently. So with that said, John, are you ready to hear about our article?
Yeah, let's hear about it.
So this article is about contingency management. The title is Contingency Management for Stimulant Use Disorder and Association with Mortality, a cohort study. It was published in the American Journal of Psychiatry, November 2025. And I've been really eager to talk about this article. It was definitely a really groundbreaking article, some data that hasn't existed before. And it's mostly about stimulants. So stimulants are the fastest growing substance use category in overdose deaths. They were implicated in 50% of drug overdose deaths in the US in 2021, and the use of stimulants continues to rise. There is good evidence that contingency management is the most effective treatment for stimulant use disorder. And because of this, and considering the surging opioid and stimulant combination overdose crisis in the US, the Department of Health and Human Services also recommends contingency management as a first-line treatment. And it's been used widely in the VA system. They have a large-scale, long-standing contingency management program. They rolled out their program in 2011. And one of the things they did, because contingency management, I'm going to describe it, but it's a therapeutic program, like a group therapy program almost. It's a little hard to track those programs. And the VA rolled out consistent note templates for contingency management starting in 2018, which allowed for system-wide data collection and system-wide monitoring of the efficacy of these contingency management programs. And this study uses that data that came from those templated notes. So just to take a quick moment, let me describe what contingency management is. So it's a sort of therapeutic technique where you select a target behavior, be it a negative urine drug screen, attending a group, so a group attendance percentage, whatever it is you want people to do. And then you get a chance to win a prize when you meet that target. So, for example, every visit you come in and you produce a negative urine drug screen, you win a prize. And the prizes escalate in value the more consecutive goals you meet. And if you don't meet the goal, like you produce a positive urine drug screen for stimulants, you get set back to the beginning. You start back where you started and you can escalate again. And so the longer you're successful, the higher your prize. In the VA, usually they draw the prize out of a fishbowl. So there'll be a bowl full of, slips of paper or whatever that have the prizes on them. And it's anything from just a motivational message that says great job to some money, $1, $2, all the way up to a jumbo prize, which might be $100. And the more successes you have, the more chances you get to draw from that fishbowl. So that's what contingency management is. It's usually part of a group. You'll be in a contingency management group that discusses abstinence and drug treatment. It's not just get the prize and move on with your life, but it's a big component of a lot of stimulant use disorder groups. So in the VA program, on average, a patient who sticks with a 12-week contingency management program will earn about $200 worth of prizes. So it's not huge. And the other factor that the VA has that we don't out in the community is that the VA has a strong kind of commissary system. So if you're at the VA hospital, there's a store and you redeem your prize money at that store at the commissary. So the commissary has donated the prizes for the VA's contingency management program. So I think I read they had donated over $100,000 worth of prizes that the veterans who are in the contingency management groups could get. If there's a group that's at a site that doesn't have an on-site commissary, they'll have like a prize cabinet that the slips of paper with money on them can be redeemed for. So people don't really get cash. They more get kind of coupons that can be redeemed for items at the commissary. So food, hygiene items, just little things. It said that what people most like are snacks and food with their contingency management prizes. So before we talk anymore, John, do you feel you understand what contingency management is, or have you ever worked with a contingency management program?
Um, I've never worked the program. I understand what the program is. It certainly sounds very novel, and I have some friends that have kind of gotten intermittent grants to do something like this, not with the VA, but it's interesting. Most people haven't heard of it though in healthcare outside of like our addiction medicine bubble.
Yeah, it's true. So this study, let's talk about this study. It was a retrospective cohort study examining the association between contingency management and mortality, as well as a secondary outcome of psychiatric hospitalizations. The data was from the Veterans Health Administration electronic health record, and then they looked at mortality from the National Death Index. They had 138,280 adult patients in the VA system diagnosed with stimulant use disorder in the study time period, which was July 2018 through December 2020. So it did overlap with COVID a little bit. And they used ICD-10 codes to identify these people in their database. In terms of demographics, of course, 93% were male, 43.5% were white. And in the past year prior to entering this study, 41% had been homeless or had housing instability. 42.7% had alcohol use disorder. 44.7% had depression. 26% had opioid use disorder, and almost 41% had been hospitalized at some point in the past year. So this is a group that's really struggling. Multiple substance use disorders, high percentage of people who are homeless, people landing in the hospital for both mental and physical health issues. So a very vulnerable population. The exposure was receiving contingency management services. So based on the EHR&O templates, they saw if you got a contingency management service, going to at least one group session. It was compared to a matched control group with stimulant use disorder who did not receive contingency management. And they tried to match for a bunch of confounders. So which facility you were at, race, gender, age, past year opioid use disorder, hospitalizations, past year substance use disorder clinic visits. So they tried to match these control patients with people who'd received contingency management. And the outcome was all-cause mortality within a year from your index date, which was your first visit at the contingency management program. They also did this secondary outcome. They called it exploratory outcome, which was the time to first psychiatric hospitalization. Because we know methamphetamine, unlike opioids, it doesn't tend to cause overdoses in such dramatic fashion, but it really does affect people's psychiatric health. It makes people psychotic, delusional, hallucinating, really unable to function in society, and people do end up with a lot of psychiatric hospitalizations from methamphetamine. And then this was done for a year. Patients were followed in a year, and it was done during 2018 to 2020, so overlapping with COVID. So any questions about the setup or the clinical question, John?
Now let's hear a little bit more about it.
So definitely some strengths. It was a very big trial. It involved a robust and well-developed contingency management program that had been around for quite a few years. So this is really the ideal state of contingency management. They included a lot of vulnerable patients who might have been, eliminated from other studies. And mortality is just the ultimate in objective outcomes. You cannot argue that it's a bad outcome. You can't argue that maybe the outcome was not, well-defined or not relevant. Mortality is the ultimate in medical outcomes. Some limitations as well, though. Of course, it's a retrospective cohort study, not a randomized controlled trial. And it was based initially on ICD-10 codes of stimulant use disorder, which may be a little bit inaccurate. The COVID-19 pandemic overlapped with the study period, which may have affected the contingency management groups. As we remember, like in-person attendance at group activities was curtailed significantly in 2020. It was almost all men, of course, so almost no women in this trial. And while I talked about how mortality is a great outcome, it didn't include any other outcomes. So it's not really about the efficacy of contingency management for stopping drugs, remaining abstinent, quality of life. Basically, it's just mortality. So there's a lot of other outcomes people care about, which were not in this study. I would love to see that in future research. And then the other limitation, like you mentioned it, you haven't really worked with a contingency management program. There are just huge barriers to implementation of contingency management. Like, it doesn't seem like a complicated concept, right? Like, you get prizes for doing what you're supposed to do. But a few things that come up. First is that any amount over $600 that you might win in contingency management prizes have to be reported to the IRS as taxable income. So both the patient has to report it on their taxes and the program has to have the, bandwidth and paperwork to record it, report that to the IRS and give patients forms that indicate how much money they won. So that's a big barrier for people. There's a lot of stigma against it. It's viewed as bribery or like paying people to stay off drugs. And the general public finds that kind of weird. It's hard to purchase the incentives. So like if you have a Medicaid program, there's not a way to purchase the contingency management incentives through Medicaid. You can't really bill Medicaid for the incentives the same way I guess you could bill for a supply or something that you might have in your office. There's also issues with anti-kickback laws because like you're not allowed to bring patients into your office and then pay them to come in for the visit and then you get money from federal services, from Medicare or Medicaid for that visit. Like that's illegal. And so there's some concern that sometimes contingency management might run afoul of kickback laws. And the final barrier is that a grant might limit contingency management to stimulant use disorder only, but it is useful in other substance use disorders and polysubstance use. And if you have a substance use disorder group, only in the biggest cities would you necessarily be able to generate a lot of groups just for one substance. Like what if someone with opioid use disorder really wants to be in your group? If you have a grant that's just for stimulant use disorder, you have to kind of turn them away, even though there's good data on contingency management and some of these other substance use disorders as well. So these are all the barriers and the reasons why this relatively simple and effective and cheap intervention is not used more often. I mean, we had done another paper on contingency management a year or two ago, and in that paper, the average amount of money was about $1 a day to keep people free of methamphetamine. And given the huge amount of costs you incur with even a single hospitalization for methamphetamine-induced chest pain or cardiac event, it's super worth it. A few $100. Like I probably ordered like $10,000 worth of diagnostic testing today, So what's like $200 over the course of a year to keep someone off methamphetamine? It's like nothing. So those are some limitations, but I think it was a great trial. So what are the results? Let's talk the highlights. Mortality, that's our outcome. In the contingency management group, there were 4.8 deaths per 100,000 patient days. In the control group, there were 8.2 deaths per 100,000 patient days. In terms of actual numbers, overdose deaths occurred in 10 patients in the contingency management group and 15 in the control cohort. So not a super high mortality, but almost double in the control group from the contingency management group. After they adjusted for all the covariates, including hospitalizations, the reduction in mortality associated with contingency management was 41%, with a hazard ratio of 0.59. So that's incredible. The contingency management group had higher rates of hospitalization. So 45.9% of patients in the contingency management group were hospitalized versus 36.4% of those in the control group. And the higher rate of hospitalization, it might not be a bad thing actually, because patients are utilizing care when they are participating in the contingency management program. And if I look at the raw numbers, in the contingency management group, more people had psychiatric hospitalizations than medical. And in the control group, there were fewer psychiatric hospitalizations, but like the same number of medical hospitalizations. So the difference really was in psychiatric hospitalizations in the contingency management group. Again, maybe not a bad thing because people are actually coming to care, whereas people not participating in the program may not be receiving care. So, John, what do you think of those results? Did those surprise you at all?
No, I mean, it seems like this is kind of consistent with what we're seeing a lot with this, right? I mean, I don't think I need to be sold anymore on the effect of this, right? I think it's more so what you talked about, the limitations of just kind of access to these programs that I think is the big issue.
Well, yeah, I mean, we've seen the data on its efficacy. This is the first really, really good data set on mortality. And I think that the existence of these sort of standardized note templates in the VA and the ability to really track contingency management over multiple years, multiple groups, multiple sites, all using a standard protocol. This doesn't exist in any other data set. This is really awesome. So in summary, the study provides the strongest real-world evidence to date that contingency management for stimulant use disorder is associated with significant reduction in all-cause mortality. This 50% reduction in mortality is similar to that you get from treating patients with buprenorphine. Actually, if in terms of percent reduction, the overall mortality is lower, but the percent reduction is the same. As you said, the issue is that it's not widely available, but there are programs outside the VA that are ongoing in California and Michigan, I think, and then a few other states have some that are coming up to have it covered and funded by state Medicaid. And maybe it'll be available soon in Pennsylvania. I mean, Pennsylvania is usually like the 49th state to adopt anything. So we might be last, or we're usually 49th. I don't know who's 50th. So we'll see when contingency management reaches us here in Pennsylvania. Might be a while. So yeah, I mean, I definitely would refer people if there was any contingency management in our area, which there's not. And then I wanted to start a contingency management group, but I'm a little unsure how to get over these hurdles. I think just persistence. I'll just keep being persistent and see if I can cut through the administrative and bureaucratic thicket to eventually get there. You think I'll be able to do it?
I would like to think that. I think this is more of a health policy thing than really kind of like a frontline medical practitioner thing at the moment. I think we just need to incorporate this into the budget somehow.
Yeah. I need a grant.
No, we don't need a grant. Because my fatigue with grants is those are great until the grant dries up and then the program just collapses, which seems to be like a lot of addiction medicine, right? It's like grants are great, but we really need this kind of in a sustained healthcare budget so that this is a service that's not going to just disappear tomorrow. It needs to be here, present, and accessible from here going forward for patients that this would help.
Well, and, off topic, I apologize to our listeners. Feel free to skip ahead. But I think the fact that so much of our care has to be grant funded is just based on, stigma and also the fact that our services aren't reimbursed very well. Like I was, not to get too specific, but, talking to some of St. Max's administrators about, we need a recovery support person in the emergency department. And then we have this other recovery support person and he's on this grant and then she's on that grant. And then this grant gives out in 2026. I'm like, how come we need a grant to pay for sort of social work and recovery support? Like we provide that as part of our care for other patients. There's a cardiology dietitian and a cardiology social worker and cardiology research nurses and, oncology has social workers that specifically help the patients get through their treatment, care navigators. How come, do they have grants? I don't think so. It's just, it's unfortunate that our services don't get compensated.
Yeah. Unfortunately, it's just kind of the way it is.
At least for now.
Yeah. Hopefully, though, I'll be optimistic about the future.
All right. Well, if I start contingency management group, I'll let you know.
All right. Well, thanks for presenting that.
It was really fun. I was really happy to read it, actually. I've been kind of waiting for this article to come out, so I was pleased to get to dive into it a little bit.
Well, thank you for listening to the Addiction Medicine Journal Club. The best part of any journal club is the conversation, and we want to hear what you have to say. To have your opinions about the articles included in a future episode, send us your comments on social media, email, or join our Facebook group. The links are in the show notes. Original theme music was composed and performed by Benjamin Kennedy. Audio editing by Michael Bonanno. CME support from My Care is produced by Dr. Patrick Beeman and Ars Longa Media. Addiction Medicine Journal Club is intended for educational purposes only and should not be considered medical advice. The views expressed here are our own and do not necessarily reflect those of our employers or the authors of the articles we review. All patient information has been modified to protect their identities. Thank you for being part of the conversation and have a great day.